In patients who you suspect the presence of DVT, the use of emergency ultrasound can provide significant benefit to both the patient and the physician. Because the treatment of DVT requires the use of anticoagulants, it has associated significant hemorrhagic risks. Many emergency departments in the United States do not have access to timely ultrasound. Therefore, the use of physician-performed ultrasound can provide significant benefits such as rapid information, decreased length of stay, increased patient safety, and increased patient throughput. Therefore, the use of emergency ultrasound is of significant benefit to both the patient and the physician. The patient is placed in the supine position with the affected leg slightly bent at the knee and externally rotated, providing optimal access to the medial thigh. The patient is undressed from the waist down with the inguinal region and affected leg exposed. Reverse Trendelenburg is also useful to improve diagnostic accuracy by increasing the blood volume in the legs. Following standard emergency ultrasound conventions, the ultrasound machine should be placed to the right side of the patient, and the physician should be comfortably seated with easy access to the machine and the patient. A linear high-frequency ultrasound probe should be used to achieve the greatest resolution. The indicator should face to the patient's right side. In rare occasions, a curvilinear probe may need to be used in patients with large body habitus and deep-lying vessels. The ultrasound software should be configured to the manufacturer's vascular settings to yield optimal images. While there are many venous structures in the leg, national guidelines direct imaging for DVT to the main deep venous structures of the proximal leg. Beginning at the inguinal ligament, the common femoral vein runs distally adjacent to the femoral artery. The saphenous vein is seen as a contributory vessel from the medial proximal region. The common femoral vein quickly bifurcates into the deep and superficial femoral veins. The superficial femoral vein runs distally in the medial aspect of the thigh and is easily seen by ultrasound. Near the distal third portion of the thigh, the femoral vein runs posterior to the muscle and emerges in the posterior-medial aspect of the distal thigh as the popliteal vein. The popliteal vein continues beneath the joint and splits into 3 branches that do not need to be imaged in the emergency department. While some controversy from other imaging specialists exists, prospective studies direct focused, detailed imaging of high-yield vessels at specific locations to evaluate for the presence of DVT. The first area of imaging is the common femoral vein just at its junction with the saphenous vein. Although considered a superficial vein, a thrombus in the saphenous vein can quickly propagate into the femoral vein to become a DVT. The second area is the remainder of the common femoral vein and should be evaluated through its bifurcation to ensure the absence of thrombus. The third area of focused imaging is the popliteal vein behind the knee. Scanning should follow the vein distally until it splits into its 3 segments, ensuring that these smaller segments are also free of thrombus. Using a liberal amount of gel, the linear transducer is placed in the inguinal region in the transverse plane with the indicator pointing to the patient's right side, regardless of which leg is being imaged. The femoral vein and artery are seen as 2 circular anechoic structures. The vein is medial or sometimes posterior to the artery and is usually a larger, thin-walled structure. Color Doppler may be used to briefly, positively identify the pulsatile femoral artery and confirm identification of the vein. Find the junction of the common femoral vein and the saphenous vein, and using a mild to moderate amount of downward pressure on the transducer, compress the vein. The normal vein compresses completely so that it is no longer visualized, while the artery can still be seen as a circular anechoic structure that pops with the patient's pulse. Release the pressure and the vein quickly re-expands. Thus, the complete collapse of the vein during real-time visualization documents the absence of thrombus in that segment of vein. Using the same compression relaxation technique, scan the remainder of the common femoral vein at 1 to 2 centimeter intervals until you are 2 centimeters distal to the common femoral vein bifurcation. Now, move the transducer to the popliteal fossa. The artery and vein are now seen on top of each other with the vein on top because we're scanning from the back of the leg. The popliteal vein is imaged using the same compression relaxation technique at 1 to 2 centimeter intervals through its entire course behind the knee down to the trifurcation. In a negative study, the use of venous augmentation can provide the clinician with additional evidence of venous patency. With the linear probe positioned transversely across the femoral vein, turn on the color Doppler function. The pulsatility of the artery should clearly be evident. With the other hand, quickly squeeze the patient's calf. This produces a bolus of blood that is propelled toward the heart and is seen near simultaneously as a color blush that completely fills the vein. A small blush, or the absence of a color blush in the vein, suggests the presence of a thrombus at some point between where the calf was squeezed and the position of the transducer, and should direct you to investigate further for thrombus. Documentation of the study should show both the open vein and its complete collapse at 3 key segments. This is best accomplished using the split screen function available on most ultrasound machines, allowing side-by-side comparison. On the left side of the screen, the femoral vein is shown without compression, and on the right side, the vein is compressed. The segment of the vein being imaged is labeled, in this case, the common femoral vein, and we've also noted that the right side is the compressed side. A similar composite image of the bifurcated femoral veins and the popliteal vein showing both its native and compressed state is mandatory. The end result in a negative study yields 3 side-by-side images, each appropriately labeled. In the case of a thrombus in a deep vein, it may or may not appear as an echogenic substance within the lumen of the vein. More importantly, a thrombus, whether acute or chronic, will prevent the vein from completely collapsing. In this patient, much of the lumen appears filled with debris, and compression demonstrates the failure of the vein to completely collapse. This is a positive test for a DVT. Note that the vein does not need to be completely occluded in order to be designated as a DVT. Some thrombi may be more subacute or chronic, thus changing their sonographic appearance. A chronic thrombus may appear more echogenic or brighter on the screen, and portions of the thrombus may have small linear canalizations of blood flow perforating through the clot. Nevertheless, the fundamental principle remains the same. Failure of the vein to completely collapse indicates the presence of a DVT, whether acute or chronic, and the treatment remains the same. Caution should be exercised when having found a DVT. Compression should be used judiciously in order to prevent part or all of the thrombus from being dislodged and propelled proximally into the cardiopulmonary circuit. Some controversy exists without significant consensus about the management of a negative emergency department ultrasound during the evaluation of DVTs. The possibility of a calf thrombus is not evaluated in the emergency department ultrasound. Therefore, patient condition, clinician experience, and local policies should guide the use of repeat ultrasounds 4 to 7 days later. With practice, emergency physicians can perform ultrasound for DVT with proficiency, accuracy, and timeliness. The keys to this are to use the high-frequency transducer, to properly position the patient, and to ensure the complete collapse of the veins at the key 3 segments of the leg.